Yeah, let's continue it. Well, we had completed the non-selective beta blockers. Then we move on to the beta blockers with additional alpha blocking effect, and they are carvedilol and labetalol. So these are the three types which we generally classify the beta blockers into. Well, for us, what is more important is the selective beta blockers, and we are going to talk about metoprolol in detail. Well, we move on to the side effects of the beta blockers. Well, they can be cardiac, they can be non-cardiac, and they can be due to drug interactions. Well, cardiac side effects of beta blockers, they are extension of their pharmacological effect, and extreme bradycardia and worsening of the heart failure are the cardiac side effects of beta blockers. Well, there can be a rebound phenomenon after the withdrawal of the therapy, and it can cause tachycardia and it can cause rebound angina in patients. So we have to be careful when you switch the therapy of beta blockers or you stop beta blockers to patients. So to be careful in cases of angina pectoris or the patients who had history of angina when you stop the beta blockers. So what are the non-cardiac side effects or the disadvantages of non-selective beta blockers? Well, non-cardiac side effects will block the beta-2 receptors in the airways or in the vascular smooth muscles, and beta-3 receptors in the adipocytes. So this unwanted action can lead to increase in the airway resistance, which is a beta-2 receptor effect, cold extremities, which leads to worsening of peripheral arterial disease, that is beta-2 effect. In type 1, it masks symptoms like hypoglycemia, maybe which presents as tremors. In type 2 diabetes mellitus, adverse metabolic effects. Well, there can be fatigue, there can be depression, which is beta-2, beta-3 central effects. Then loss of libido and impotence also seen or associated with the beta-2 effect. So these are the non-cardiac side effects which are associated with the beta blockers, well, especially beta-2 and beta-3 receptors. Now we go on to the beta-1 and the beta-2 receptors which are there in the heart, where 70% are beta-1, 30% are beta-2. Well, overexpression of beta receptors leads to ventricular remodeling, development and progression of cardiomyopathy and apoptosis. Well, whenever there is an overexpression of beta receptors, it will cause ventricular remodeling, development and progression of cardiomyopathy and cell death. Well, beta-1 blockade is required, and so it is beneficial. We don't want a cell death. You don't want a cardiomyopathy. So if you block the beta blockers, then definitely it will be beneficial for the patient. Well, beta-2 receptors in the heart, the stimulation in the beta-2 receptors, it protects against apoptosis. So this is a beneficial effect. Then it preserves the cardiac output by maintaining inotropic effect on heart and by peripheral vasodilation. So beta-2 receptors blockade is not required and is not beneficial. So you need to have the beta-2 receptors, you want to block the beta-1 receptors. So this is an excellent slide which highlights the importance of beta-1 blockade, and it also highlights why you don't need to or why you don't require beta-2 blockade. So we go on to understanding of what is apoptosis. Well, apoptosis is programmed cell death or cell suicide. Well, different from necrosis, where the cell death occurs due to causes external to the cells like ischemia, toxins, and etc. Well, apoptosis is it leads eventually to cardiomyopathy. There will be an overexpression, that is more number of receptors and increased stimulation of beta-1 receptors, which promotes apoptosis of the myocardial cells, whereas stimulation of the beta-2 receptors protects against the apoptosis. So beta-1 and beta-2 receptors, they counteract the apoptosis. So if there is more or there is overstimulation of beta-1 receptors, then it can cause cell death, whereas when there is stimulation of beta-2 receptors, it actually protects against the apoptosis. So inference is beta-1 blockade activity responsible for not only activity, selectivity and cardioprotection. Beta 1 blockade is required and is beneficial. Beta 2 is responsible for non-cardiac side effects and loss of cardioprotection. Beta 2 blockade not required and is not beneficial. On the contrary, you require a beta 2 activity, right? So how to overcome the disadvantages of non-selective beta blockers? Well, by developing selective beta 1 blockers like metoprolol and atenolol. Well, they are selective beta 1 blockers and preferentially block only the beta 1 receptors, hence they have lesser side effects. Well, known facts about metoprolol. Well, metoprolol is beta 1 selective adrenergic receptor blocking agent, so it is cardioselective. It is accepted in the therapy for myocardial infarction, angina pectoris, hypertension, cardiac tachyarrhythmias and heart failure. Well, now we are going to take the individual therapy, like why it is prescribed, why beta blockers, cardioselective beta blockers are prescribed in post-MI prophylaxis. Well, myocardium has recently suffered an injury. It has suffered an event which has basically caused cell death, that is necrosis of the tissues, so it needs rest for healing. So metoprolol, what it does, it decreases the heart rate and the force of contraction, that is negative chrono and inotropic effects. So when there is a decrease in the heart rate and the FOC, that is a force of contraction, oxygen demand and oxygen consumption of heart also decreases. Well, the risk of reinfarction decreases. So risk of cardiac arrhythmias decreases. So a risk of sudden cardiac death will also decrease. So they are better prescribed in post-MI as prophylactic agents. Well, what is the role in angina, hypertension and tachyarrhythmias? Well, in angina, there is a mismatch or an imbalance between the demand and supply of oxygen. Well, metoprolol actually decreases the oxygen demand and relieves the angina. Well, in hypertension, it reduces the heart rate and the force of contraction and reduces the cardiac output and hence reduces your blood pressures. Then in cardiac tachyarrhythmias, it reduces the abnormally high heart rates, which are more than 90 beats per minute. So they are helpful in angina, in hypertension, post-MI prophylaxis. Well, in heart failure, well, we have discussed in detail about chronic heart failure or congestive heart failure. Well, we have even spoken about the etiopathogenesis of CHF. Well, what it does is we have already discussed this slide there, so I want to highlight it again. It decreases the heart rate, it increases the diastole, that is a period of relaxation, hence increases the ventricular filling time, so there is a resultant stretch on the myocardium which improves the force of contraction and this improves the cardiac output. Well, it has to be used in caution in cases of heart failure, because it can worsen the cardiac output when the heart rate is low or when the heart rate or when the patient is suffering from bradycardia. So what are the known facts of metoprolol? It has got no intrinsic sympathomimetic activity, ability to cause some stimulation on its own while blocking neurotransmitter action. Then second is rapid and complete absorption, moderately lipophilic, then elimination by hepatic metabolism, that is 95% of the drug is metabolized in the liver. Half-life is 3 to 7 hours and immediate release. It crosses blood-brain barrier and has CNS effects. So these are the known facts of metoprolol. What are the issues related with metoprolol? Well, it is cardioselectivity is not absolute. At higher plasma concentration, it also inhibits the beta 2 receptors. So this is a point which we need to discuss or we need to talk about with the doctors, that it causes inhibition of beta 2 receptors which are actually beneficial for us, which need not be blocked. So we want a fairly cardioselective drug which works even at high plasma concentrations and does not block beta 2 receptors. So, lot of interpatient variability in the metabolism leading to unpredictable clinical response. Then, third is drug interactions with the commonly prescribed drugs, not safe in hepatic dysfunction patients because it is 95% is metabolized by the liver. Then, what is the selectivity of the isomers? Let's talk about that. Well, preferred receptor S-metoprolol and is beta 1. Where you can see the selectivity ratio 33 times more selective towards the beta 1 receptor. So we know that the metoprolol has two isomers, the S isomer and the R isomer. So what you inference what is drawn from this table is that your beta 1 receptor has more selectivity towards your or the S metoprolol has more selectivity towards the beta 1 receptor blocking, whereas R metoprolol generally blocks your beta 2 receptors and it has got 10 times more selectivity towards the beta 2 receptors. So this is again we don't want a beta 2 blocking activity. So when you give a racemic metoprolol, what happens is it blocks not only the beta 1 but also it blocks your beta 2 receptors, and it can cause apoptosis and all those points which I have referred to as which are not required during the beta 2 blockade. So we don't want a beta 2 blockade because we actually want beta 1 blockade or a selective drug which acts more on the cardiacs on the cardiomyocytes and helps in reducing your heart rate. It helps in the basically it reduces your force of contraction. So all these effects are what we require from a metoprolol. We don't want the beta 2 activity of metoprolol to affect the different receptors and cause other side effects, other complications. So henceforth we have got a chirally pure S-metoprolol, which we'll talk about later. So beta 1 receptor blocking effect on the racemic metoprolol resides solely in the S isomer. So if you are giving a racemic mixture, it is your S metoprolol or the beta 1 receptor selectivity is due to S metoprolol. So why give the racemic when 33:1 is the ratio of beta 1 receptor selectivity of S-metoprolol? Then why give the racemate? Because racemate on the contrary has a selectivity towards the beta 2 receptors. That is the R isomer in the racemate has a selectivity towards your beta 2 receptor. So why give this racemic drug? Why not prescribe just the chirally pure S-metoprolol? So what is now we will talk about the metabolism. We have already discussed that 95% is metabolized by the liver, 50% first pass metabolism. Now there is a group of enzymes which act and they are called the cytochrome P450 enzyme system, and CYP2D6 is an enzyme which is required, which is essential for the metabolism. And there are two broad categories of population. They are the extensive metabolizers and the seconds are the poor metabolizers. Extensive metabolizers are those humans who metabolize metoprolol normally, that is adequately, and poor metabolizers are those who metabolize metoprolol poorly, that is inadequately, and this incidence is up to 30% in the population. So if they are not metabolizing metoprolol properly, then there is a problem if you are giving racemic metoprolol to these patients. So we will talk about this later. Well, to sum up so far, metoprolol is cardioselective beta blocker, important place in therapy, but has certain drawbacks: loss of cardioselectivity at high doses, preventing titration to the recommended dose 200 milligrams per day for maximum benefit, variable clinical effect, and drug to drug interaction. So the R isomer of the racemic metoprolol is the major culprit for all